Hello and welcome to part one of this two-part webinar series of promising practices for improving access to primary care in northern, rural, and remote communities. My name is Colleen Ferris, and I'm the Director of Innovations and Strategic Development here at Healthcare Excellence Canada. I'd like to start by acknowledging that we are meeting on land that has been inhabited by Indigenous peoples since the beginning. In particular, we acknowledge that we are broadcasting this webinar from Ottawa, which is located on the traditional and unceded territory of the Algonquin Nation. I acknowledge and I am humbled as a settler and deeply appreciate the historic connections to this place and the opportunity to gather here today. Please note that the session is being recorded. We are pleased to offer French simultaneous interpretation for this session. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. We invite you to share your questions and comments at any point using our chat box, and we encourage all of you to respond to comments and answer questions in the chat as you wish as we go along. To ensure that we have time to hear from all presenters, we will hold a question and discussion period during the last 15 minutes or so of today's webinar. And at any point, if you require technical assistance, please don't hesitate to send a direct chat message to tech support, soutien technique. As mentioned, I'll be your host for the next hour, and I'm thrilled to have Linda Lee and Larry Bremner with me. Both Linda and Larry are program coaches for strengthening primary care and have been with us throughout this journey for the past year and a half. Linda is a passionate advocate for using evaluation to create a more equitable, inclusive, and sustainable world. Larry, who is Métis, brings 45 years of experience in social research and evaluation. Linda and Larry, it has been an absolute pleasure working and learning from you. I'm going to pass the floor to you to introduce yourselves before we get going. Over to you, Larry and Linda.
Thank you. Is there a slide?
Just look, yes. I think the next slide is about the discussion today. Yes, yeah.
Okay. So I'm Larry Bremner. I'm Métis, as Colleen said. I was born in Prince Albert, Saskatchewan. My great-grandfather and his father were two of 30 Métis men that signed a petition that was sent to the Canadian government protesting giving their land to the Prince Albert Colonization Company. That was ignored. They both fought at Batoche, moved to the United States after Batoche, and came back to Saskatchewan in 1905 and homesteaded in Dormy. I'm a former national president of the Canadian Evaluation Society, and as past president, I argued for and I guess was a driving force behind the setting up of a new global network called Bell Indigenous, and I'm currently a co-editor of Roots and Relations, Celebrating Good Medicine and Indigenous Evaluation, which can be seen in the Canadian Journal of Program Evaluation, which is an open access journal. Thank you.
Thanks, Larry. I'm Linda Lee. I come from a white settler background. At home, when we're in Manitoba, we are on Treaty 1 territory and the homeland of the Red River Métis. And I put our land acknowledgement for Arizona as well in the chat. Larry and I, some of you know, we are work and life partners. We have a company called Proactive Information Services that Larry established in 1984. I am also a former national president of the Canadian Evaluation Society, and an avid dog lover who does many different things with our dogs. So we will be talking more later. Good to see everybody.
Thank you, Larry and Linda, and looking forward to hearing more later. We'll also be joined, so Larry, Linda, and I will also be joined by 3 additional speakers from teams in the Strengthening Primary Care program, who will share about their promising practices that have improved access to team-based primary care in their communities. So for today's discussion, we'll hear about and discuss example promising practices to improve safe, including cultural safe, team-based primary care in northern, rural, and remote communities. For the example promising practices, we'll share and discuss key success factors and lessons learned to support implementation, sustainability, and spread, strategies used to enable community, health workforce, and First Nations, Inuit, and Métis partnerships, reflections, and how can these promising practices and strategies be adapted and spread elsewhere. The promising practice summaries are all available on HEC's website, and the link will be added in the chat. Next slide, please. So about the Strengthening Primary Care teams, the Strengthening Primary Care program brought together 20 teams of primary care providers, organizations, and communities from November 2023 to November 2024. They represented several northern, rural, and remote communities in 10 provinces and territories across Canada. One of the 20 teams, Newfoundland and Labrador Health Services, advanced 5 unique promising practices to respond to the needs of people and providers throughout their province. Teams at all stages of the improvement journey participated, including those in planning, implementation, or spread. All 20 teams had a common overarching goal: to improve equitable access to safe, including culturally safe, high-quality, team-based primary care closer to home in northern, rural, and remote communities. However, each team implemented a unique promising practice to reach that goal, devised to best meet the needs of their communities and partner and providers. Unique focus areas of the promising practices included, and certainly not limited to, those that focused on improving support and retention of the workforce, innovative models of care, improve access for people with and without primary care team, appropriate virtual care, chronic disease prevention and management, mobile health teams, First Nations-led governance structures. Supports that HEC provided throughout the program included seed funding. Teams had up to approximately $50,000 available to them. Virtual and in-person networking, coaching, and learning events to promote sharing, learning, and collaboration. Co-development of summaries of promising practices to help teams share and to help generate discussion about how similar approaches could be adapted and applied elsewhere. And be supported to advance a promising practice to improve access to safe, including culturally safe, team-based care. 19 teams shared with HEC their final report to share about the impacts they achieved, including from patient and provider stories, and the value they experienced by participating in this program. This slide shows some examples of overall program impacts. Over 66,000 patients were directly reached by the promising practices that were advanced through this program. Example impacts shared included improved provider experience, such as greater work-life balance and joy in work, reduction in emergency department visits for conditions that could be safely and appropriately managed in primary care, improved patient experience and access for patients, changes that promoted culturally safe practices through relationships and partnerships with First Nations, Inuit, and Métis, and other equity-deserving communities. Teams shared stories and quotes from community members, patients, and people in the workforce as an important indicator of impacts. Some are shown on this slide. We heard from a nurse sharing that with the original nurse on call, my on-call nights are so much easier. I can sleep and be rested for urgent situations. Without it, I don't think I would still be working up north. From a team member, 75% of patients report that being seen at the annex helped them avoid an ED visit. A patient partner shared with us, this program changed people's lives by helping with their pain relief and being able to get that treatment in their own community instead of having to travel hours to get it elsewhere. In the final reports, we also asked teams to share some key factors that contributed to their success. Examples of success that they shared with us included collaboration with the community and health workforce to ensure practice met their needs. the flexibility to adapt to challenges in community workforce input, the sharing and progress of and good news stories with the team and the community, the funding to help fund equipment, positions, and community engagement, and a team with time to do the work, including leadership, measurement lead, and team lead support. We also asked of other lessons learned that they'd recommend others consider if adapting the practice to their own community setting. And some of these examples included be a visible presence in the community. It's about meeting people in person, helps build trust, and provides deeper insights into community needs, ideas, and opportunities that can inform the improvement journey. Building a diverse team with multiple champions to sustain the improvement journey, even in the face of staffing challenges, time pressures, and the complexity of change. The planning and thinking of sustainability from the start to ensure the people and resources are in place to maintain as organizational and community priority. And not being afraid to change the plan to reflect community, team, and staff input. So those are some sharings of what we've heard from the teams. And now we'll invite 3 of those strengthening primary care teams to share about the promising practice they advanced throughout the program, as well as a reflection on the value of the HEC program for supporting them to advance their work to improve access to safe, including culturally safe team-based primary care. As mentioned, if you can keep questions and comments coming in the chat, and then we'll save space at the end for questions and discussion following all of the presentations. So here to speak on behalf of the government of Nunavut and their extending health center hours promising practices, I'm turning it over to Maya Nakajima. Over to you, Maya.
Thanks so much, Colleen. Much appreciated. Good morning, everyone. My name is Maya Nakajima, and I'm the Director of Special Operations with the Government of Nunavut, Department of Health. I have the privilege of calling in this morning from the unceded ancestral and traditional territories of the Squamish, Tsleil-Waututh, and Musqueam nations, and I'm delighted to be able to share some of our experiences with the HEC Strengthening Primary Care Initiative. So our challenge, as many of you may know, Nunavut is comprised of 25 remote fly-in-only communities. Each of our communities has a singular community health center that's mainly staffed by nurses. These health centers are typically open Monday to Friday, 9 to 5. However, we do know that many Nunavut, our community members, access the health centers after business hours through an on-call nurse. This may indicate that our current hours of operations are not consistently meeting the needs of our community members. The high volume of after-hour calls also contributes to the on-call staff not getting enough rest between shifts, and as you can imagine, can increase the cost of the overall health system. Additionally, given the size of the health centers, we have limited clinical space and physical infrastructure that makes it difficult for us to actually increase staffing during the day-to-day sort of regular business hours. Evening hours may allow additional staff to share the limited space more effectively. So our promising practice, across the Department of Health, in partnership with our community leaders and providers, we are piloting extended health center hours in 3 Nunavut communities: Rankin Inlet in the Kivalliq region, Pond Inlet in the Qikiqtaaluk region, and Kugaruk in the Kitikmeot region. This initiative is guided by 3 of the 8 Inuit societal values: Inuqatigitsialnik, respecting others, building relationships, and caring for people; Pigitsialnik, serving and providing community; and Kanuktumlik, being innovative and resourceful. So we implemented back in the fall of 2024, and we're expecting our final results summer 25. Our preliminary results are really positive. We've had tons of positive feedback from both community members and staff, which is really exciting for us. Our evaluation criteria that we're monitoring include community and patient experience, of course, after-hour registrations, staff experiences, and staff overtime and the associated costs. 2 of our key success factors have been just broad-scale leadership support and ongoing communication with folks. We've had significant buy-in and engagement throughout this project, everyone from our community members, including the mayors and the members of Legislative Assembly, who represent the participating communities, from our frontline staff, and certainly with our executive leadership across the department. This really has been a made in Nunavut for Nunavut kind of initiative, and it aligns quite well with the broader department goals around improved quality of care and care closer to home. Secondly, it's been wonderful having an evaluation consultant, like a dedicated person to really build out a robust evaluation framework for this work going forward. One of the key unanticipated learnings that we experienced that might be applicable to other jurisdictions stemmed from the use of online surveys. So pre-implementation, we had deployed an online survey that was intended to go out to just the community members of the participating communities, just to understand their current use patterns of their health centers. And as a result of the survey being online, we got unanticipated survey responses from bots, from folks outside of Nunavut, outside of Canada, in fact. And so with our evaluation lead, we were able to develop specific inclusion and exclusion criteria to help us filter through the data received and helped us to strategize how to better ensure stronger, better quality data for us going forward, especially because the community experience is really one of our key metrics. Just briefly touching on the value of the HEC funding opportunity, certainly being part of the SPC community has been incredibly helpful for us across the GN. It's funded in part our evaluation consultant. It's given us the ability to provide gift certificates for some lucky Nunavut mute. We've had access to and certainly leveraged quite a bit the expertise across HEC in the areas of Indigenous health, rural remote health center operations, and also evaluation, of course. It's been a really wonderful opportunity to build relationships with the HEC team and also across jurisdictions, and it's been great learning about all the innovative work that others are leading right now. And so, in short, we're quite thankful for the opportunity and really look forward to collaborating with HEC and other jurisdictions and well into the future. Nakomik, thank you.
Thank you, Maya, and it's thank you for you and the team and all that you have done and the learnings that we've shared with you and all the others, and congratulations on all the work and continued successes. We'll now invite Jessica Brennan from Newfoundland Labrador Health Services, who advanced one of the 5 promising practices across that jurisdiction, to share about the primary care pop-up Carboneer Impact Clinic. Over to you, Jessica.
Thank you, Colleen. My name is Jessica Brennan. I'm a manager with the primary care program here in NLHS. I'm in the rural eastern zone, which of course is Newfoundland and Labrador, which is the ancestral homelands of the Beothuk, Mi'kmaq, Innu, and Inuit peoples. So I'm excited today to tell you about our Carboneer Impact Clinic. So in Conception Bay North, which is where I am seated today, about 1 in 5 patients lack access to team-based primary care or a family doctor. So this leads to an increased reliance on emergency departments, EDs, as the primary access point for care. Long wait times in the ED means that many people leave without receiving care, and furthermore, those who are seen in the ED only receive episodic care based on their presenting complaint and not access other services or preventative care. So our promising practice was to create the Carboneer Impact Clinic. So it's a partnership between the CBN Family Care Team and the Carboneer Hospital ED. So private community physicians agreed to work in shifts in the CIC on a rotational basis. Patients are triaged from the ED to this clinic when care needs are appropriate for primary care assessment. Patients are seen through the CIC instead of the ED and receive care for their acute needs while also being offered preventative screenings such as Pap smears, cancer screenings, and chronic disease management. So optimizing treatment for diabetes, heart disease, chronic lung disease, etc. Patients without a family doctor are also added to the provincial registry, which is Patient Connect NL. So some of our example impacts that I'm really excited to share with you today. We've been operational since August 2024. The clinic is open between 2 and 3 days a week based on physician availability. In September 2024, our real first month that was operational, 175 patients waiting in the ED were triaged for CIC. Of these, 156 received care at our CIC clinic. On clinic days, our ED wait times decreased significantly. The percentage of patients leaving without being seen dropped from 15% to 0. The wait time for CAC is less than 1 hour from identification of patient to patient seeing physician. Reduced number of patients waiting in the ED positively impacted the well-being of our ED providers and staff. I wanted to share a couple of patient examples with you. So we had a 91-year-old patient who attended the CAC who assumed he was end of life, was planning for that stage of his life. However, once connected to our physician, our nurse, and our social navigator, our dietitian, and our seniors link worker, is now living independently at home with a med adjustment and attending card groups. Really exciting. Secondly, we had an individual recently, a 23-year-old, who was actually deemed as not fit for work due to her complex medical history. She was assessed by the CIC physician and nurse, able to access the medication that she needed, was linked to our social navigator, and has since seen drastic health improvements and is now working in the community as a home care worker, which benefits not only the client, but our community as a whole. So up to date, to the end of February, we have seen just under 1,000 patients in the CIC. So our keys to success. So administrative and nursing support was provided by the family care team. So our family care team is rooted in that team-based care. Flexible employment model where the physicians from private community clinics could self-select shifts and have the infrastructure available to them to support the service delivery. So the physicians were working out of a clinic that was adjacent to the ED, so different weight room, but close enough that if folks relied on taxi or friends for rides, they were able to access our service instead of the ED. So flexible employment model. Sorry about that. So referral pathways were developed to our team-based here at the CBN Family Care Team. So that improved health outcomes for our patients as they were able to be referred to our occupational therapist, physiotherapist, social navigator, chronic disease nurse, or other service. Partnerships were really a huge key to success. So several internal programs, so the ED family care team, but as well as our external partners. So our family practice network, our private community physicians, and our community advisory committees. So this really was a patient-centric project. The patients kind of led the project, I think it's fair to say. We ensured continuity of care by giving the physicians and the nurses protected time to follow up with the patients that were seen in CIC. So if they didn't have a family doctor, our RN Kelly she quote unquote adopt these people, and make sure they had follow up for all of their tests that were ordered through CIC, and if necessary, book them in for follow-up appointments. And champions. So our local rural community physicians were our champions. They guided a lot of this work and told us what works for them, what the barriers were to doing similar walk-in style clinics in the past, and we learned a lot. So on that, in the segue into lessons learned. So our CIC improved access to care for people without a family doctor. Initially, when writing the grant proposal, I hypothesized that we would see a lot of unattached patients, but in reality, 60% of the patients that we saw actually were attached to providers in the community, but their access to the patient was not adequate or timely. And the CIC helped ease the burden on EDs while ensuring residents receive timely and comprehensive care. And just a quick reflection, because I know I'm running out of time, but being a part of the HEC grant and this project has been invaluable. I've learned so much. I was a new leader when I entered my grant submissions, so I feel like I've grown so much through the project, and the support of Jennifer Major and Colleen and her team, and my coach Kevin has been absolutely fabulous. So hope to be, I feel like this is the end, like we're breaking up, but I hope not. And I hope to continue to work with you all in the future. Thank you.
Thank you so much, Jessica. And no, absolutely not. You can't, as we joke, we stay very connected to our team. So, and I'll be sharing, actually, maybe this is a good plug to keep everyone on for the end of the webinar, sharing more about some opportunities that HEC is getting ready to launch in the coming months that connects to this work. We'll now invite Janine Vanden Heuvel from the Algonquin Family Health Team to speak about the annex. Over to you, Janine.
Thanks a lot, Colleen. My name is Janine Vanden Heuvel. I'm the Executive Director of the Algonquin Family Health Team. We are located in the district of Muskoka, which is situated on the Robinson-Huron Treaty and Williams Treaty territories. The challenge that we were trying to address at the annex was really a challenge that most of, I think, North America is seeing right now, which is a lack of access to team-based primary care or family physicians. Our wait list that the Family Health Team brokers in Huntsville is currently at about 5,000 unattached patients. And this shortage leads to an increased reliance on emergency departments as a primary access for point of health care. That's not ideal for several different reasons. We believe that the emergency department should be there for emergencies, and that comprehensive primary care is the most appropriate place for primary care. So our promising practice is called the Annex. It's a comprehensive, team-based, nurse practitioner-led primary care clinic. It's housed in a part of the community library for people who do not have their own healthcare team or family physician. The clinic provides the right care in the right place and ensures the patients that are discharged from inpatient care from the hospital receive routine comprehensive follow-up to promote recovery and prevent readmission, and helps patients to having to avoid seeking care in the emergency department. And it also happens to avoid readmissions of patients that are discharged from hospital who aren't attached to a practitioner. To date, we've had about 500 discharges from the hospital directly into the Annex for follow-up with comprehensive primary care. Since we opened in 2023, the Annex has provided over 8,000 visits. That number has been updated since the promising practice was printed. We provide primary care for about 3,000 unique patients who would have otherwise had to have sought care in the emergency department or not had care at all. We definitely have pockets of the District of Muskoka that are isolated. Transportation is, probably what you would expect with a rural and remote community, and patients do tend to go without until it's, beyond the scope of primary care, and then they are at high risk for becoming ALC, which aligns with the provincial healthcare priorities. We see about 45 patients every day at the Annex. 75% of those patients report that if they had not been seen in the Annex, then they would have gone to the emergency department. Patients are reporting great experience, as are the providers, and we provide some follow-up care and specialist services. So we have expanded to provide specialized geriatric care, mental health and addiction therapy, and physiotherapy within the Annex. Providers report great work and life satisfaction. Providers report also high level of satisfaction with employment at the Annex. So we really are a comprehensive team within the Annex. There's a handful of providers that are salaried by the Algonquin Family Health Team, and we have rotating physicians coming in and out of the Annex billing fee for service. And that's also opened up opportunities for locum positions within all of Muskoka, especially since we are a bit of a destination. If you're not familiar with Muskoka, we're a bit of a destination for seasonal residents, visitors, and people coming in and out of Algonquin Park. So that's really attractive for locums and the physicians not having to pay overhead or sign long-term contracts or have to find their own staff, admin staff or nursing support staff. So again, adds to the flexibility and improved work-life balance for everyone. Our keys to success really are our partnerships. The funding that we received either is in kind or financial support. We received that from the town of Huntsville, the Northern Ontario School of Medicine, of course, HEC, and Ontario Health. Our champions include a lead physician to recruit and engage community partners and primary care providers to mobilize services, a project lead to establish and manage day-to-day operations, communicate progress, and grow the program over time, community organizations and partners to ensure that the Annex meets the needs of Huntsville residents and provide appropriate financial and operational support. Work flexibility and work-life balance. So incentives include part-time hours, no overhead fees for new physicians coming in, and that makes it easier to recruit and retain doctors. We have a team of allied professionals, and that includes nurse practitioners working to top of scope, doctors providing comprehensive team-based primary care. We also have a nurse working full-time in the clinic, and a really innovative program through the District of Muskoka, which is community paramedics, that provides in community and in clinic support. So for some of our more isolated or homebound patients, we can refer to the community paramedic program, and they can be seen in their homes and in community where they reside. Our lessons learned. Take time to create and foster partnerships with people, communities, and organizations. We needed that to finance and to guide our operations, but we also needed it to help the clinic grow in a way that was supportive of the community that we're serving. without community partnerships, we just wouldn't be possible. The lesson learned really, and a big part of the strengthening primary care, is the ability to collect and monitor data to inform ongoing improvements to ensure we're meeting the needs of our communities. But it also builds a case to help sustain and grow the annex over time. One of, I think, the problems with primary care is that, especially when it's nurse practitioner led, is that we lack a lot of OHIP data in Ontario associated with that. So the ability to really have a robust data collection and reporting system with HEC is something that we haven't really had before. And we find that, it's a bit of a perpetual cycle where we're too busy and we don't have the funding for good data collection. And then we don't have the basis to, build a business case because we don't have the data. So this is really adding to really an overall, I think, push in primary care to get good, robust data and data equity through northern and rural communities. I really just, and I guess another lesson learned is really just the importance of comprehensive team-based primary care. I think primary care is really having a moment in Ontario where people are really understanding what this sector is and the importance of the sector, maybe for the first time. And I think that this project has really added to that as well. Thank you.
Thank you so much, Janine, and to you and the team at the Annex and all that you've accomplished. And once again, Maya and Jessica, for sharing your experiences as well. So we're moving into the discussion and questions segment, and I've seen a few questions popping up in the chat. So thank you for that. But first, I'm going to invite Larry and Linda to provide some reflections as coaches for the program on what you've heard so far today, as well as what you've seen as the value from coach and working with the teams you've worked with throughout this program. Over to you, Larry and Linda.
Thanks, Colleen. I'm going to sort of reflect on our role as coaches. I really think that it was valuable bringing the teams together in Winnipeg last year in person. It really allowed team members to share ideas and strategies across teams, and I thought it was a really positive experience. Linda and I were asked to do a presentation, and I think it enabled us to present a different approach to evaluation, which appeared to really resonate with a number of the teams, and hopefully going forward, this will prove useful for teams and in terms of how to incorporate stories as well as numbers into your evaluations. As a coach, it was really exciting to see the innovative ways teams developed their projects to address access to primary care. And as a coach, it really struck me the commitment and dedication of team members to getting their project to work in a positive way and have positive outcomes and serve the community and help patients with better healthcare delivery. And my only other thing is, and we talked about this, I think, before, is that possibly there's a better term than coaches to describe the role that we play with the teams. So those are my reflections. Linda's and our reflection as coaches, and I think Linda's going to talk about what we heard now.
Yeah, I'm going to take just a couple of minutes to talk about some of the things that stood out to us. And then Larry and I will talk about what we see as sort of the value added of having HEC support these projects. So one thing, and I have to start with this, is we heard of the importance of evaluation and of having good data. And so that is always really exciting to hear. And I think also the importance of both having numbers and stories, like some of the numbers from these teams, the number of people who have now received access, the reduction in wait times, the reduction in ED visits, like those are really impressive numbers. But we also saw that the stories are really important. And so, we need to find those ways to get those stories. And, sometimes things like surveys don't always do it for you. The other thing we heard about was the importance of partnerships. That those take time to build, but they're really crucial, not only in terms of implementation, but in terms of sustainability. And those partnerships speak to the importance of your local context and understanding where you need to build those partnerships. Related to that is the importance of leadership and having champions. And we heard a number of people talk about having multiple champions. And again, that's what supports sustainability of these projects. Something we also thought about was that not only have these projects improved access for patients, but they have also supported improving work-life balance and joy in work for the providers. And so maybe sometimes we think those things are mutually exclusive or in conflict, but no, in terms of these projects, it seems as if those things are mutually supportive. And before I move on to the value of HEC, Larry, do you have anything to add?
Not really. I mean, it was mentioned about the cross-jurisdictional collaboration, and we saw that in Winnipeg, but throughout this project, and the importance of not being alone, I think, was an important aspect of this.
Yeah, and I think that is where we really see the value added of having Healthcare Excellence Canada, is that over and above the funding, there is really a community of practice created, and we just heard someone say, I hope we don't lose this. And so that was done through multiple ways, not only through the in-person meetings, but which also was great for coaches to actually meet their teams in person, but also through things like webinar, online meetings, sharing of information. So I think that was a real value added rather than just giving funding to people. Larry, did you have some other things to speak about?
I think one of the other value addeds is that HEC encouraged the teams to think creatively in terms of solutions. And we're encouraged to take chances, and HEC was supported throughout. This was about creativity and finding appropriate solutions. So I think that was really important. And the pop-up summaries, things that HEC develops for the teams, it's for sharing widely to raise awareness of the creative work being undertaken in healthcare. I think that's really important. The last team mentioned how important this project was to increasing awareness of primary care in Ontario. So this is just another way to increase awareness to what's some of the creative things that are going on in healthcare. That's.
Oh, I think you're on mute, Linda.
Yeah.
Oh, sorry.
All good.
I just saw Kevin put in the chat about it's been a valuable learning experience for coaches as well, and I would just like to second that opinion.
Mm-hmm. Yeah, I agree.
Yes, and thank you. Well, thank you, Larry and Linda, and acknowledging Kevin Sampson. And I'm sure many of our other coaches from the program are joining us today. And I'd like to invite Jessica, Janine, and Maya back on camera, as well as we're going to open up a bit of a discussion. And Larry, I loved how you talked about the creativity that's happening. And I think that is something I can say it's very inspiring to see these teams. And I know at HEC, we see this in all of our programs, the creativity and the desire for all teams to make improvements in the health system to make sure it's safe and high quality for the communities and working with the communities they serve, while also making sure, I know as HEC, we want to support teams to pivot along the way in order to meet those community needs and that. So, and Larry and Linda, welcome to keep your cameras on too, as you're a key part of all this. And we have had a few questions come in, and we'll do our best to get to all of them. But knowing that the promising practices have been posted, there's contact information on those as well, and we'll be sending information after this. I'll start with the question that came earlier on And it was Jessica, it was about a question about how the family docs are staffed at the CIC clinic. Were they funded? Were they paid? And were any patients attached to primary care teams beyond the testing follow-up on the issues seen in the clinic? And how many unique patients did you see?
So thanks, Catherine, for that. So our physicians were paid through MCP, so which is our provincial healthcare plan. They were given billing codes. They were able to directly bill to MCP, which is what they would do in their private practice. They just did it with no overhead and with the support of the family care team. So let me, what else was, how many, so we did have a couple that we found through the work that were on a wait list for us that we tried to reach. So the ones that we did connect to our family care team were ones that we couldn't reach otherwise. So their cell phone was out of minutes or they had moved, which is a couple of the issues we see quite frequently. So we have a mandate to attach chronologically from our provincial lists. We weren't able to take on it. We would love to have taken the 1,000 that we met because they needed some support, but we took the ones that we came across. Oh, we tried to call you last year, and unique patients. So I don't have that number right in front of me. That's a really great question. I think the majority were unique. We did have some folks that we had coming back because we're concerned about them, and no one really used it as, I guess, their primary care. I guess as a primary care provider, but the recurring connection piece did happen, and we do have some patients that come back that need follow up and have nowhere else to go. Versus like folks that waited a year and emerge every year, a day and emerge every year to get their prescriptions refilled, things like that. So we're trying to keep our RN Kelly has a little book she calls Little Black Book. So all the folks that really need us, we keep tabs and in touch with them.
Thanks so much, Jessica. Janine, there was some questions about the selection of the library, and I think this is when we think of primary care and I think that's one of the many unique and beautiful things of what primary care is maybe there's a view of where it traditionally needs to be provided, but it's not necessarily the case. I know there's some information you shared in the chat, but we just wanted to check in if anything else you wanted to share about the selection of the library and just even how that might have been felt more opening for folks to access as well.
Thanks. Yeah, I mean, it was an available space, really, that was owned by the town of Huntsville. That was one of our partners. And we are very lucky to have the town of Huntsville as a partner. Not every municipality necessarily sees themselves in the healthcare space. Huntsville does. So we are, again, very lucky to have that. This really isn't a regular library anymore. This was an adjacent kind of community space, a large space that's adjacent to and connected to the library, but right now it's for exam rooms and a waiting room, so it doesn't look like a library anymore.
Thanks for sharing that, Maya. And I'll put this question to you, Maya, first, but also welcome Jessica and Janine to reflect on this too. So what's next? As we've formally ended the HEC portion of it, but we know lots of the work that you and team are still doing in with the government of Nunavut and that. So just any items you'd want to share about what's next.
Absolutely. Yeah. So we should be finishing up the pilot sometime in the summer, June, July, August of this year. And so once the analysis is done, we'll be able to use it for some decision making as to whether or not we continue on as regular operations in these three clinics, whether or not we are able to expand the same practice around other community health centers. So there's a lot on the go right now and a lot to come. We're really positive. We're optimistic that the results will show that this has really been a benefit to both community members and to our teams. And so, you know, if fingers crossed, we're able to replicate this across additional communities.
Thanks so much, Maya. Jessica.
I'm really happy to report that our CIC clinic is still in high demand. We are operational when we have physicians. We're looking at having right now a virtual hybrid model for the days where physicians aren't present to be a 5-day-a-week service because there are no other walk-in options in our communities around here. And I will say that thanks to HEC's funding that actually have 2 promising practices, they are both running now with a very low cost of the health authority with the MCP billing piece and the already existing infrastructure. So I'm really optimistic that ours will continue on in perpetuity. So yeah, I'm excited. We're talking about other opportunities for unattached clinics, similar to what our Western friends have done across the Eastern Rural Zone.
Wonderful. Thanks so much for sharing, Jessica. Janine, what's next for the annex?
So the annex has been able to secure provincial funding for the next 3 years, really because we have good numbers and because we have been robustly and dedicated to the collection and dissemination of our data. So thank you to HEC for that seed to be able to do that. It was really important for us. I've been doing a bit of a roadshow talking about the annex at various expos and conferences, especially as it pertains to, I guess, the different professions. So the community paramedics want to know what it's like for the community paramedics, and the nurse practitioner they all want to know what it's like for the nurse practitioners, which I guess would be a good segue into the question in the chat, if you don't mind. So really, there's no difference clinically between what the family physicians and the nurse practitioners are providing in the annex. The nurse practitioner visits tend to be a bit longer. In Muskoka, we kind of have a bit of a toehold with comprehensive nurse practitioners rostering their own patients and running comprehensive primary care clinics here anyway. I think to a patient, the only difference would be that, for an MTO test, they pay out of pocket, and for a nurse practitioner, they're salaried, so the patient doesn't pay out of pocket. Really, everything else should be kind of seamless and unnoticeable to the patient.
Thanks so much, Janine. Maya, there's a question about, were there any challenges, adaptations required to create extended hours shifts for the community health nurses work late hours, especially in regards to union working hours?
Great question. Thanks. I was just responding to it right now. You got me sooner than that. So we worked very closely with the Nunavut Employees Union to ensure that we're able to support the evening clinics, that we had nurses available to work the evening shifts. The evening shifts at all 3 health centers run from 1300 to 2100, so 1 o'clock in the afternoon to 9 p.m. And essentially the communities themselves, we've really leaned on the expertise of those on the front line in understanding what models work best for their context. They set their minimum number of community health nurses that are required to actually operationalize the pilot. And so they also have, in partnership with them, we've developed a decision tree that helps to identify, what to do with the pilot when there aren't enough staff. So do we pause it? Do we do a rotational schedule? Do we have a dedicated nurse who works only the evening shifts? And so it's been really a great partnership with them. And again, only successful because of the strengths of the frontline staff.
Thanks so much, Maya. I'm going to pick up, ask a question, and it's pulling from what Larry and Linda shared, and certainly we know as the teams came together February 2024 in Winnipeg, and it was also a great opportunity that not just our HEC's strengthening primary care teams, but HEC's cultural safety program teams were also there to really allow all of our mutual learning and growings together. And Larry and Linda, during that time, as you noted in your remarks, the importance of evaluation, but also the opportunity for us to shift our thinking of other ways of doing evaluation, and the impact of storytelling also, not just the number data piece. And wondering, Jessica, Janine, and Maya, any reflections from learnings at the Winnipeg event, also about different ways of doing evaluation that you've been able to bridge in as your work continued on, after that time we were all together.
I just want to hop in quickly and say Larry and Linda's presentation at that event really pushed me to the value of stories, and that's why I felt it was important to include within all of our evaluation. But today, especially, that's the part, and I actually got to meet two of those patients, or one of the patients, sorry, that we discussed today, and really learning how the experience was for them. I think also I just wanted to highlight meeting other managers, leaders in rural and remote communities, to think like I'm all the way in Eastern Newfoundland. I met somebody all the way in Vancouver Island and we have the same challenges, which is so interesting to me because I'm like, oh, we're in Newfoundland. We don't have any doctors, we don't have any transportation, but that's not just us. So it's nice. It's almost like, kind of Missouri problems love company, because we have so many people around the table who really care about patient care and care about equity and equality. And I was so, when I left, I came home, I was just like, to my husband, I'm like, I'm so inspired. I'm at the right table finally. I met so many people that are like-minded and really care about their rural and remote communities, which is, I'm a rural girl at heart. So I absolutely loved that conference. So thank you.
Thank you, Jessica. And I think it demonstrates the power of community, and especially sometimes when we're in the workforce and we're looking down, sometimes we know it's the opportunity to know that we're not alone, right? And that there's a broader network and how we can learn from each other. We're at the time where I actually need to move into the next portion, but do know Janine, Maya, and Jessica have given so much of their time throughout this program, and to share your learnings and taking the time today. I encourage all folks to look at theirs and all the other promising practices. But as I put a bit of a plug in earlier, I wanted to share about some upcoming work that HEC is going to be launching publicly more in April and May. So this is really some first time we're more broadly sharing this, and together we know we can get better together. So we want to improve health outcomes, care experiences for patients, providers, and the value and equity of care. And we're working towards at least 1 million people across the country. And how we're going to do this, we'll go to the next slide, please, is we're doing this around work around 4 transformative targets that support system change that also aligns with federal, provincial, and territorial priorities. These connect to expanding safe, person-centered care in long-term care, supporting more older adults to age where they call home, improving work environments for healthcare providers and leaders, and expanding access to care and easing pressure on emergency departments. And we've just heard of a lot of great examples today. But we know that while we have these important transformative targets, it's also about, at the same time, building those foundational skills to sustain excellence and foster high-performing health systems and teams across this country, while also uniting a pan-Canadian community of learners and leaders making lasting change. Specifically, as it relates to expanding access to care and easing pressure on emergency departments, through our policy and analysis and work and learning from so many promising practices that are occurring across the country, we know that this can be achieved in many different ways, from supporting community-based health promotion and disease prevention, expanding access to robust primary team-based care, enhancing appropriate care through service integration, so thinking of integrated care, and enabling role substitution, health workforce improvements, and changing and advancing practice roles. So in order to help us work towards those ways, we are going to be launching some point in May 4 offerings that will allow all of us, hopefully across the country, to come together, and teams can look to join one or more of these offerings that is all seeking to expanding care and access and reducing pressures on ED visits. There's going to be one about primary care access improvement, and this is related to a trusted quality improvement model that improves timely access to care for patients to their primary care teams. It is following the advanced access, but with a quality improvement support around that. There will be a paramedics and social prescribing offering that will help systematize paramedic teams using use of social prescribing to connect patients with local and non-medical resources to improve health and well-being. We'll also be launching a lighter touch program called Enhancing Integrated Care. And we know many of our promising practices and others that folks are doing across the country, such as virtual care, connected medicine, and other integrated service models of care, all towards safer, higher quality care that can be delivered at the right time, right place, by the right provider. And finally, also a right care challenge. This will be an awards-based challenge, and that offers resources and recognition to teams leading solutions through various approaches that address this transformative target. So these are all ways that we are going to be looking to keep this work going. And on the screen, certainly please feel free to join our emailing list if you're not already connected, because as more information about these offerings are shared publicly, you'll be able to get information about that. And so we're now going to ask you to complete a short survey, and this will help feedback for us about who's joined, but also how you've feedback that HEC. We always want to continue to learn and grow from each of these webinars. So we thank you in advance for taking the time. And as you complete that survey, once again, a big thank you to Maya, Janine, and Jessica, not just for joining us today, for all the work that you and your teams have done throughout this program, and also throughout every day, the impact and changes you are leading and supporting to make care safer, including culturally safe care for more people in Canada. For Larry and Linda, and we know Kevin and others, are coaches who have supported, who have guided us as Team HEC, as well as the funded teams throughout this. This all would not be possible without you. So I know some folks might still be completing the survey, but again, big thank you for joining us today. We look forward to staying in touch, and we look forward to hopefully seeing many of you in part of our upcoming offerings. Thank you.